send the messages to.
Look at this.
We're live.
We're live. I guess we should stop our friendly banter, huh? Just kidding. That's why people are here. Welcome everybody to this month's edition of Tech Docs Lunch Chat. It is my name is Dr. Brad Brown. This is Dr. David Cameron. Conveniently, we're both located in the greater Denver area, but that doesn't matter for this. But yes, we are excited to do this again today. It is always fun to go back and forth and share ideas and hear a lot of what some of the audience has to say as well. We did a poll a little bit ago for what people would like to hear on these lunch chats, and today's topic of managing labs, referrals, medications, and more was the most voted on one. So we're going to take it from there. Quick intro. Again, Dr. Brad Brown. My clinic is in the North Denver area. I have 2 locations. I've been in the DPC world for a number of years, all the way back to medical school. So take it away, Dr. Cameron.
Hey, good to see you again. Dave Cameron, DPC doc in Littleton, Colorado. Ours is pure family medicine. We got 4 docs there. And if you do have additional topics that you want to be hearing, and then we could have some debate and some voting stuff about what kind of things we want to talk about in future episodes, we'd love to hear it. Just drop it into the comment section. Did you have a holiday joke you wanted to share?
We were just talking about this.
Let's skip it.
Let's skip it. We need a laugh track for it to actually work. But no, yeah, happy holidays, everyone. This is a great time of year. We saw 61 sick people last week, acute sick visits in 5 days. So it was nuts. And then it all came to me, and then I gave it to my kids. So
yeah, we had the stomach bug that ran through our family, which was not fun.
Yeah, I know, right? So what would you like to talk about first? How do you manage some of these things in DPC? Where do you want to start?
Labs. Let's talk about labs.
Yeah. What do you do?
So we have got a contract with LabCorp, and so we draw labs in our office, and we give our patients the option. We say, do you want to use your insurance? Do you, or do you want cash pricing? So we've got a cash price with LabCorp, and it's just shocking how low the prices are. And so for like a standard panel of labs, which might be several $100s through insurance, our price is about $45 for some standard annual labs. So many of our patients that have insurance, we ask them, say, hey, do you want us to bill it through insurance or cash? And a lot of times, if they're not going to meet their deductible, they will choose to use our cash price instead of going through insurance if they think they're not going to meet their deductible.
Right. So, even with what I've seen is, even if they are going to meet their deductible, there's still the draw fee and the lab fee that are not covered, so they have to pay that anyway. It's like a copay. And so they're like, well, the copay is more than what your cash rate is, so I might as well just go through you. And that's kind of what ours have said.
Yeah.
Do you have any point of care labs in your clinic?
We do. We do the standard flu, strep, COVID, mono, urine dip, pregnancy tests, and we don't charge for that stuff. We just we do that. What about yourself?
I do like all the gadgets and gizmos and bells and whistles, and so I've thought about getting some countertop,
analyzers,
lab stuff, for A1Cs and even a quick CBC or something. But I mean, LabCorp just and Quest and the local labs, they just make it so easy. Their couriers come once a day, and our nurse just draws them in office, and so and there's various lab locations all within striking distance of us. We're in a metro area, so. While I do love taking up giant footprints of counter space with, kitchen appliances and lab appliances, I don't think I'll be getting one. Although in theory, I would love one. So if anyone's listening that has an in, I'll take one, But yeah, we do the same thing with flu and COVID and everything like that. Strep, fun stuff.
So do you do a different process than what we do? Do you have
just order them through the EMR? We use the Hint clinical system. I know you use the Elation. Just bidirectional, very similar to what you do, and what a lot of other docs do. And we just send the order, or either we do it here, or if the patient wants to get it drawn at LabCorp, and then it goes through our LabCorp account and we pay that bill, but then it's charged to the patient automatically. And so we can collect that money. We don't mark it up at all.
Jeff's got a good point here. He said, word of advice, have a form for them to sign when they opt to have insurance billed, so when they do get a $500 bill versus the 40, they don't say, you never gave me this option. Love it.
That is
Thanks, Jeff.
Dr. That is a man speaking from experience. We've all been there too. It's like, oh my gosh, whoops. Something reflexes, or you put in the wrong test order, right?
And we have a difficult time once we go through insurance, and then if a person says, hey, I don't want to pay $500, then to try to backtrack and pay cash, we have a difficult time with that process. And so it's almost like at the time of the draw, you got to decide which one you're going to do. And there's no going the other direction. Has anybody else have you had any luck backtracking?
No luck backtracking. I mean, even if our nurse, she'll call LabCorp if we need to switch tubes or something, or like the processing, if we're short a tube, is there another tube we can use? And even that takes 2 hours on hold, for crying out loud. So backtrack, and that's how, I mean, a lot of our patients understand the client bill pricing, but whenever you get a new patient and they're like, oh, I'm supposed to use my insurance or something, that's when it gets a little tricky. So
and a lot of patients are wanting some labs that aren't covered by insurance, like ApoBs and CRPs, and sometimes testosterone and some hormone things like that. And I find that when I try to bill those through insurance, they're really expensive. But I've been shocked. Like ApoB plus a lipid panel through LabCorp, our price is $16 for that, and our CRP cardiac is $13. So I just tell people, this might be a better option for you. Sometimes if people want to do the ones that they know will be covered by insurance, we can split it up. Sometimes we'll say, okay, we'll run these ones through insurance, and these ones will be cash. And we've had some success with that.
Nice. Yeah, I haven't had to split it out yet. I'll keep that one in my pocket.
Yeah.
Yeah.
What do you do like Gallery Labs or Cleveland Heart Labs?
Yes and no. I mean, I think the whole Peter Attia outlive thing that's going on is fantastic. It's getting a lot of people, including myself, to think deeper, right, about their health and how to age gracefully and outlive and everything. I don't particularly seek out patients and say, hey, you should do this. If they come to me, we have that discussion. We talk about the pros and cons and everything. And if it is a decent fit, then I'll order them.
Okay.
I don't think there's anything wrong with that at this point, other than maybe finding something that we can't truly diagnose for 10 years. But that's neither here nor there, right?
Yeah. So. I'm assuming that everybody is aware of Grail and Gallery, and for those that don't, it's a blood test to check for methylated cancer DNA floating in the bloodstream to check for about 50 cancers. Cost $949, and more patients are starting to ask me about it. The negative predictive value is pretty good. It's like 98%, but the positive predictive values, I think they advertise as 43%. And so I've ordered it for patients. I've yet to have one that's positive. Yeah, but that being said, it's interesting. They said that if you do a workup and the workup is negative, so if it's kidney cancer, you do the imaging. If the test is negative, they'll do a repeat Gallery for free in 3 months, so that you can evaluate the discordance.
I didn't know that. It almost sounds like it's more data for them to be able to build their data set. I like that.
Yeah.
That's cool. Yeah, I had one that popped positive after we had the long discussion of, hey, we won't be able to really find what's going on just because of, we're not there yet in the technology world and the imaging and everything. They were fine with it. And they're like, okay, I'll retest in 5 or 10 years. Okay,
yeah.
We're here for you.
We asked him how often you should do the Gallery test. And there's not a current recommendation.
It's too new.
Yeah, I think it's too new, and who knows exactly how long it takes to go from a really early stage to a later stage cancer. But I
Yeah.
think that they're probably going to start pitching it to be an every year, every 2 year test, and it's not to replace any of the current cancer screening. It's in addition.
Yeah.
Yeah.
Probably
So,
get there in the future. For
yeah.
now.
But man, it's clearly not an evidence-based option, but it's something that people are starting to ask for.
Yeah. The evidence will come one way or another eventually. But
Yeah.
just got to wait. I love waiting. Cool. So what do you do for referrals? Talk to me about your referral process. Someone comes in, they need to see a cardiologist. What do
Yeah.
you
Well, I remember in the past, probably, I don't know, 10, 12 years ago, we used Healthcare Blue Book to identify like who were the top value. We look at, price, and I know there were scorecards. I found that was helpful for about a week. I mean, usually it wasn't very good for cardiology. It was more helpful for radiology and for surgeons and stuff. Then we switched over to Castlight. When Castlight was still doing transparency stuff, we took a look at that, and then we did Grand Rounds, which is primarily quality. They look at quality more so than cost. Then I was with an organization where we were able to get a bunch of claims data, which I currently don't get. But that was really helpful because then I could take a look and see how much it costs the plan for the specific test, or for the echo, or for the colonoscopy, or for the surgery. Sometimes you can get some data from the carriers. Now, I actually find that for me, I think the principles that I've learned are try to refer to as many independent specialists as possible. Refer to the direct specialty docs. I love, my favorite cardiologist takes no insurance. And I don't know if you refer to in Colorado, for those of Colorado, Dr. Yesman, he's in Denver. He just takes cash. It's like $150 for a consult for him. I think he charges $200 for an echo, and he gets people in next day. It's like DPC for the cardiology world.
Fantastic.
Yeah. And for rheumatology, in Denver, there's a cash only rheumatologist.
Mm-hmm. There's an endocrinologist that just opened up in Boulder, a direct endocrinologist.
Yeah. Well, I think the specialists are in the same scenario that we are. They hate the system, and the ones that decide to buck the trend and go direct care. Jeff said, "Good luck finding them in Greater Boston." Yeah, I just think that there's going to be pockets of places that might have this, and other places. We got a lot of physical therapists that do cash only now.
Yeah, I took one of my kids to the ENT not too long ago. We were just chatting. Obviously, I tried to hide that I was a physician for as long as I could, but he figured it out pretty quickly. And I was talking about DPC a little bit, and he said, "Oh, if you ever need a pediatric otolaryngologist in your practice, let me know." I said, "I don't know if I have the volume to support your salary right now, but we'll see about it in the future." Yeah, it's direct specialty care, direct primary care. We all know, I'm preaching the choir. It is a product that sells itself on both sides, for the doc and the clinic, and the consumer, the patient. So, do you have like a Rolodex of who you trust? I tell my patients all the time, hey, I'm not just going to refer you to some Joe Schmo down the road. As we were building the practice a few years ago, this is kind of weird, but I did a lot of legwork. I went and met with a lot of specialists. Usually the specialists come to primary care because they want our referrals, but I would go cold call them and meet them and see their space and see if they knew what they were talking about. So I could kind of put them in the fold and say, okay, I trust this person with your knee surgery or your heart or whatever. Do you have like a place where you, outside of your head, because obviously you know everything, but who you refer to?
Yeah. Well, one other principle before I answer that is only referring to surgeons that operate in ambulatory surgical centers, unless you want to pay 3 times as much to have them operate in the hospital.
Yep.
And so the orthopedic groups that we that we partner with are ones that have their own ambulatory surgical centers. Same thing with the GI groups and stuff. And so I think those are that's low hanging fruit in terms of finding good value. But to answer your question, yeah, no, our group, we keep track of those that patients like. If people like them, then we keep track of them. If we get responsive notes that are helpful, we keep track of those. Right now, cost is difficult to get just because we don't have one single source coming, because we're high retail and small employer groups. How about you? What's your process?
Yeah, similar. I mean, just to piggyback off the cost point, I mean, it's hard because a specialist who's in the insurance world, the specialist doesn't know how much their visit is or the procedure is. Staff doesn't know. It's like, who's the decision maker on what the price is? It's hard to find who to ask. So I mean, we put a referral in, we'll fax it over. I'll have my nurse fax it over to the office. And then we just keep a close eye. We hear, you just hear things. Hey, so-and-so did really well. I just had a patient text this morning. I saw a psychotherapist that was really incredible. You should meet with them. Okay, yeah, sure. I'd love to. I think very highly, and this might seem a little high horsey. I think very highly if someone sends me a very clear, precise note and basically says, you can manage this in your office. Please text me if you need anything.
Yeah.
Don't clog up my schedule with this garbage, is kind of reading between the lines. I love that. And if it's like, hey, this is exactly what you need to do. This is exactly what I need to see this person for again. Go forth. They're like top of my list. I'm happy to refer to you for that, just because it's easier for all three parties, the specialist, for me, and the patient. So
yeah. Are you using any of the e-consults like Thea or Rubicon, or had much experience with that?
Yeah, I love. I've used Thea for a little over a year now. Personally, I love the concept of e-consults because there's a lot of times, I mean, DPC is a little bit lonely sometimes. I mean, you have 3 colleagues, I have 1. There's a lot of single doc shops, and we're not here at the same time all the time. So I like having a specialist, just like, I know the answer. I know what this rash is, but I'm just going to bounce it off the dermatologist just because I have them there, And Thea, I like Thea because it's a flat fee every month as opposed to per consult. And so I can use them as much as I want. Sometimes I feel like a resident, like, hey, can you help me? I don't know this rash or this murmur or something, but I'm fine with that because it's only for the benefit of the patient. So personally, I'm a huge fan of the e-consults. Obviously, there's things that specialists need to see in person, but as a next small step, kind of beyond primary care, I can give them my thoughts. Is this something I can do in office? Is this something that I should send?
And how does the financing work for Thea? Does the patient pay for the consult? Do you pay for it, or how does that work?
Yeah, so Thea is just a once a month charge, and they recently got together and came together with Hint. But that's just cost of doing business for me. I don't charge the patient at all. I think it's a really fun and cool value add to say, hey, let me just text a endocrinologist real quick, and patients love to hear that. Even though I don't know that consultant personally, but I can just, throw a quick message. It almost gives a little more credibility to our practice. Like, oh, they don't have to refer me right away. They're going to ask the specialist if it is a referral worthy issue. And so I see that as cost of doing business personally. I know Rubicon and some other ones are structured a little bit differently, but in the end, it's all the same for the patient.
Okay.
What do you?
We got a question here. How did you get your first employer client?
Oh, I'll leave that up to you. I just gave a long answer. I'll answer it too.
Oh, okay. So mine is the CEO of the company was my patient, and I just tell him, hey, you can have this be a benefit to your client. And so he decided to add a high deductible healthcare plan, and then everybody that's on the high deductible healthcare plan gets the membership for free. Those that are still on the PPO plan, they have to pay half, and so then he now pays for everybody, and their employees love it. It's one of their favorite benefits. So
side before I answer, for you, for the employees who are not like, they didn't just find you on your website and sign up. So have you had any that have left that company and still signed up with you later? Or is there,
I don't think so. Not
okay,
yet, but
they've all stayed with the company pretty much.
yeah.
Yeah. I was talking with a DPC doc a couple weeks ago, and he said it's just a little bit of a different thought process for some of the bigger companies. He had a company with 70 people sign up with him, and those patients almost treated him like just an in-network doc. He felt like it was a lot more legwork to explain what DPC was, and so he had a great idea. He went and bought lunch for the whole company. They had a whole meeting with all 73 people, I think it was. He said, "This is an investment in my sanity," and he went and just gave his spiel. This is what direct primary care is. This is what you get with this benefit, and it was a phenomenal response. So I thought that was pretty cool. Not necessarily, obviously, across the board, but side tangent. Yeah, for me, mine was the same way. I joined a bunch of local networking groups just to meet a bunch of other small businesses. And one of the she was an employee, one of I think 12 at the company, and she brought it to her boss, and I met with her boss, and then they went, yeah, this is fantastic. So they paid for the whole membership, and then the patient or the employee covers any additional cost for labs or anything like that, medications. So it didn't happen overnight, that's for sure. There's a long lead time with employers. They take a while to find the decision maker and to actually sign up, pull that trigger.
I think if you know the person that's the decision maker and who has a financial incentive to make a better, less expensive benefit plan, and someone who is not risk averse, the problem is that sometimes you talk to HR directors and they're risk averse and they'll be hesitant to do anything that could potentially jeopardize their job. I think it's really important to talk to the CEO. I think, yeah.
Definitely.
Hey, should we move to meds? Here's Greg said, "Do you dispense meds? Value added?" ?
Absolutely, to both of those. Yeah, I'll go first. So in the DPC space, there's kind of two buckets of thought, and some of it is laws. Some states you can't dispense more than a day or two of medications. So if you're in Texas or New York or Utah or one of the other states, then you can just mute us for now. But yes, I think it's huge value, especially for the patients who are either uninsured or underinsured or don't have a pharmacy benefit or things like that. Or if it's an urgent care thing, a quick amoxicillin or Augmentin out of the office is $4. And so it's, you can leave. I like to say when I do a meet and greet, yeah, you can come in for a sick visit, and if you need it, you can leave with medications in hand. You don't have to go stop and wait at the pharmacy forever. So definitely some value added, but I'm probably 70-30, 70% calling it into local pharmacies, 30% dispensing out of office. But I don't withhold out of the office from anyone. It's just if it financially makes sense, or if they don't, some people are like, no, I'll just do it at the pharmacy. I'm like, okay, it's more expensive and takes more time, but it's up to you. Go ahead.
What company do you use for your medications?
Personally, for us, we use Animeds, Bonita Pharmaceuticals. Those are the two main ones. Kind of just shop back and forth to see who has the better price.
And so just to remind me how ANDA comes in large bottles, and you need.
Not necessarily.
Do they come in prepackaged bottles, right? Or okay.
Yeah. So for the losartans and stuff, we'll get the 500 or 1,000 pill bottles. But for some of the odd doses or something like that, we'll just get the 90 or 100 pill bottles and then just throw the label on that and give it to them. So
yeah,
we've
also prescribed in-house. About 12 years ago, I found that it was so helpful because the cost differential between getting them through the DPC versus the pharmacy the delta was pretty large. I found that the delta is starting to shrink a little bit now with GoodRx and Mark Cuban and some other options. I think the two main things, it was convenience. So when people came in, it was really nice for them to walk out with their amoxicillin or their first fill for a new chronic med. And it was also nice for cost savings. I don't know if the cost savings is quite as good as it used to be. I think it's still there, but I don't know if it's quite as good. We're starting to transition out. I think the pandemic has made a lot of people do their urgent care virtually.
Mm,
And so a lot of times we're doing a ton of urgent care and the patient's not there. And
yeah,
so then I'm sending it into a pharmacy and having them get it, and we'll use GoodRx or their insurance.
yeah,
And the other thing is that our clinic is not open as often as the pharmacy. And so the pharmacies, can have that benefit of evening hours, weekend hours, the
yeah.
storage space in the clinic. I mean, I remember we were like, okay, how many different doses do we carry of lisinopril? And how many sertralines do we carry? Do we carry the 50 and the 100, or we just carry the hundreds and have people cut them? And storage space got to be a little bit of a hassle. And we also would lose some money because things would expire. And so I don't know. We still have it, but I think we're doing less and doing some more through the mail order. But we've used Northwind.
Nice.
They were good.
Yeah.
But I know people use ASM and Directs as well.
Yeah, those are good. I think those are cool programs now, to where you can basically add in on a per member per month, and they get access for basically free meds for up to whatever the formulary is for 500 or 1,000 of them. I think that's pretty cool. See how that pans out. No, what you're saying is pretty common thread. I talked to a few, clinics and owners and docs in my role at Hint, and they all say the same thing. They're historically with DPC, it was like you have to dispense out of your own office. That's a pillar of DPC, and now it's like, well, you really don't. So it's kind of a cool shift that is kind of swinging one way. But
we had a terrible experience one time with dispensing meds, and it was because the employer said that if you get the medicines from the DPC clinic, the prescription will be free and we'll pay for it, and we would just bill them directly. And we got flooded, or like half of our MA time was just doing refills. Yeah. It was such a mistake.
No kidding. Well, you live and you learn, right?
Yeah, and I was like, I am not a pharmacist. I don't want to be a pharmacist. I want it to be a convenient and to help people save some money. But I think that the value add is for me to be a doctor and to be a great DPC doctor.
Yep, there's a reason pharmacies exist.
Hey, question for you. What are you doing with really expensive meds? So like if people are on Mounjaro or Ozempic, biologics, and how are you kind of navigating the difficulty trying to get medications to be more affordable for patients?
Yeah, that is the fun part of the game, right? I mean, you can get the starting dose of Ozempic. Actually, you can get all the doses of Ozempic for about $950 a month. So I have a small handful of patients that pay that, and so I order that in wholesale, and here you go. Other times we try to play the insurance game and try to get them to be able to fit the boxes that they want. Or GoodRx. I personally had kind of people come in and say, "Oh, I can get this compounded for only 10% of the price," and so we try to have the be careful talk. But honestly, it's just trying to play either the insurance game or getting people the wholesale cost, which not very many people want to pay $1,000 a month, but
yeah,
people do.
Well, I was at the Hint Summit. I was chatting with a couple of DPC docs that are using semaglutide from a compounding pharmacy.
Yeah.
Just from what I've been reading, I'm scared to do it. I guess I'm just maybe too risk averse. I don't know if there's other DPC docs out there that have had good experiences with it. I haven't done it yet, but I know it's a lot cheaper.
Yeah, I feel the same way. It's like, I don't know. It's totally up to you, but if it was me, probably not. So that's neither here nor there. Yeah, I mean, the expense in biologics and stuff, that's similar. A lot of times they come from, if they're on Humira, they come from a GI doc or something. Then I'll talk to the GI doc and see how we can do it best for the patient. And if it comes from a GI doc, usually it's covered by insurance, things like that. I don't have any cash paying patients that need any biologics. Like just the other day, Nurtec, that's a really expensive one, a couple $100 a pill.
Yeah.
And they have a really good patient assistance program. So I'll just do that for the patient, as opposed to having them do all that paperwork, just so I can help figure that out for them. But it's, the nature of the big pharma. You got to play their game sometimes.
Are you? Here's hot topic: samples.
So,
What are your thoughts about samples?
they're free. I love free, right? And you can't sell them, which I also love. I don't know. I think they have a place. It's not. My mind is not it is not in the same headspace as the drug reps who drop them off. They want the samples to go out and then you to prescribe, and then they get paid and all that stuff. I think if a patient wants to try medication for a couple months and you have the first month of a sample, it's like, sure, why not? If it's within the realm of safety and if there's no contraindications. So I have no problem accepting samples. All I do is sign my name. I don't accept anything else from the drug reps, just on principle. But a lot of our samples just expire because we don't really give them away. So what do you do?
We do very few samples, just if it's an expensive medicine that a patient might need. I wish we could get Manjaro, but can't. We've had no luck getting samples, even though we asked the Eli Lilly rep for it. But
yeah, we get like one from our Eli Lilly rep every 3 or 4 months, and it's like, I don't want to give this out to one person for 1 month, and then they start telling their friends they get it for free, and then I'm inundated with, hey, you gave it to them for free. I'm just not going to do that.
Well, I've actually had some people that don't have diabetes get their Manjaro covered. Maybe it's just their insurance that's good, but I usually tell them, try your insurance, try GoodRx, try the Manjaro, the Eli Lilly savings coupon. And I found that Costco has been more helpful than Walgreens, CVS, Rite Aid. Those ones, they have not been very willing to work with patients to try to find some discounts. The one thing that I find that they make us jump through is they make us go through a prior authorization to prove that it fails before we can use the coupon. And I don't know why that is, but I think maybe they just want to make sure they can potentially get a higher reimbursement through insurance first. And then once that fails, then they'll use the coupon, which I think is a lower reimbursement.
Creative.
So,
yeah. So what about when someone needs an MRI? What do you do?
So we use freestanding independent radiology groups. So our local one that we use the most is Health Images, and they're one of the green imaging locations. So for those of you, Green Imaging is a national organization, and they partner with a lot of local organizations that are freestanding, and they've got really good cash pricing. So most of the MRIs, depending on contrast, no contrast, it's around $450 to about $550. That's the price for our MRIs. So a guy had no insurance. I had to send him in for let's see here. It was an MRI of the brain, and it was $450. So that was pretty good. And then the CTs are in the 300s. Ultrasounds are, I think, about between $200 and $300. And then $60 for X-ray if it's 3 views or less. And then I think it's around $80 to $100 if it's 4 views or more for X-rays. The mammograms are about $200 to $210.
So usually in October they're even less. They have discounts for mammograms and stuff.
Okay. Yeah. What about you? What's your?
Yeah, very similar. Obviously, we're geographically close, so those prices are what I have seen. We use Health Images, Touchstone, things like that. Even Sally Job downtown. But as I was starting to partake in the DPC Kool-Aid way back when, then everyone said, "Oh, you need to negotiate with the local imaging centers to get the best rates." I did not have that experience, so I called around trying to find who can I talk to get a cash rate first, and they won't give us a list because they're worried that we'll publish them. but they will let us know how much things cost so we can write down our own list pretty much. But yeah, and it's a lot of experience of okay, this was only $300, this was $450, and we kind of just have a general idea. And patients appreciate that, to be able to say, okay, it's not going to cost me $900 with insurance. It only cost me $400. Yeah, absolutely, I'll do that. So deductible not included. So how would how would you suggest someone who is starting out to get set up with an imaging center? Just start referring to them, or what would you say?
Oh, that's a good question. I think if it's a completely new community if they don't know the 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 institutions, who's independent, who's got facility fees, I'd call. I would first just go or show up and just meet and say, hey, do you have self-pay prices?
Yeah.
What about patients that have insurance? What are those contracted rates? I mean, I think I'd try and get some more information.
Yeah.
I haven't run into that problem since I've never done that. I usually am pretty well acquainted with the services, but or I would say someone who's just going into a new community, starting up a DPC, I must say I applaud you. That's bold. That'd be great. I think most DPC docs that I know, they start a DPC up in a community that they've done fee for service, or they did the residency in that area.
And the area for me personally, I mean, yeah, I did residency right down the road, but I've piggybacked off of the legwork that you've done in Colorado and in general. DPC is pretty well understood here. And so at least I get people, I just had a family sign up the other day. Hey, we just moved up from Castle Rock. We're seeing a DPC doc down there. We just want to, sign up the DPC doc up here. And they said DPC, and I was like, oh my gosh, you're golden. Yeah, absolutely, sign up. You understand it. I don't need to do my pitch. But yeah, and a lot of imaging centers understand that as well. The Touchstone rep, she comes by every now and then. She has quite a few DPCs that refer to Touchstone, and so she understands it, and so she is a little more forgiving when it comes to, hey, how much does this actually cost? She'll kind of give it to us with less flack. So yeah, it is not easy. We do have one question from Greg again. Why don't most physicians, especially non-DPC, seem to care about the cost of medicine for their patients? I thought my role giving my patients the most appropriate care, including care they could afford. So why don't they seem to care about it? Honestly, I think it's because both parties, the patient and the doctor, are blind to how much things cost. I think that's the simple answer. I mean, what would you say?
Yeah, I'm just thinking about the days when I did fee for service for about 10 years. The first thing is I was so busy that I would say that I was trying to survive. It was not that I didn't care per se. I think it was more that I was too busy to research and too busy. And I wasn't the one that was actually deciding where they go. I would just put an order in for an MRI. Somebody else, then the referral coordinator, would make the decision where they go and would make the arrangements. And so the same thing would be true for referrals. So I would put in cardiology referral, and that would be it. I wouldn't say who or where or which organization. I would just say orthopedics, and it would be out of my hands. And so I worked for a hospital system, and of course they would refer within the hospital system because that's the way they are incentivized, and that may or may not, probably not, be the most cost-effective, high-value location. And a lot of those images would be there would be a facility fee in addition to the cost of the image plus the physician fee.
Yeah, I mean, that last statement, Greg, is spot on with the DPC mindset of first do no harm, but do no financial harm as well, right? You want to be able to find a way, but it is a time thing. It is a bandwidth thing to where, me as a human, I want to finish my notes and my orders so I can go to my kid's soccer game. And that, might be more important that day than if you can save $100 on an MRI, if that requires some time. That's a tough mindset to be in the fee for service world.
Yeah.
It's the moral injury and the burnout come from things. This is one of the issues, right? So
I also think the reason why DPC doctors are incentivized to care about cost is that, first off, we do want to take really good care of patients and we want to help them from a financial standpoint. But also, if I'm able to help them save money, they will stay in my practice. And that's good for my bottom line.
tell their friends about you.
Employers, if particularly if they are a self-funded employer, which most of the time where small DPCs are not with self-funded employers, but as we get into larger networks, we're going to have more self-funded employers. And if I write for an MRI that costs $450, then that employer only has to pay $450 for that. That's assuming that it's going to hit the plan. And if I go to a place that is in the hospital network and it costs $2,000, then frankly, that differential may make or break the relationship I have with that employer. And so anyway, so I just think that DPC's incentives are aligned with patients and are aligned with employers.
Absolutely. Spot on, as usual. Thanks, Greg. You're too kind. You also rock. Cool. So I know we're coming up on time. Just a quick plug. Hint has a great ecosystem of vetted partners, DPC friendly partners. Here's the website where you can go and find and explore for everything from pharmacies and things like that, and programs, everything that we've talked about and more. It is fantastic. And even a more selfless plug, those partnerships, my wife happens to help manage those partnerships at Hint. So she's doing a great job. I know she's listening and she's blushing right now because she didn't want me to give her a shout out, but I will anyway. Cool. So let us know if there are any other topics you would like to have covered in the future for these Tech Doc lunch chats. And we will take it from there. But this has been a lot of fun. Thanks everybody for listening. Thank you.
Hey, everybody have a great rest of your 2023 and we'll see you in 2024.
Absolutely.